Hi guys, this is Jason Williams DO. This is the Williams Family Medicine channel helping you to live your best life. Today I wanted to visit with you about apolipoproteins. If you look at your lab work, you will often see lipid profile, which might include triglycerides, total cholesterol, HDL cholesterol, LDL cholesterol, and even VLDL cholesterol. Another way to look at your lipids is to look at what's called apolipoprotein profiles. This might include Apolipoprotein B, Apolipoprotein A, and a ratio of the two. As this is a complex topic, I wanted to have a video that my patients can access to gain further understanding about what we're trying to do with this test. As a physician, the reason I care about these things is I want to try to reduce your risk of cardiovascular disease. Cardiovascular disease is the #1 cause of death in the United States. As of 2020, there were about 19 million cases of death attributed to cardiovascular disease. Cancer is about half that. Your risk for cardiovascular disease certainly increases as you get older. Someone who is 70 years old has about 5 times risk of death of cardiovascular disease versus someone who is 30 years old. It does seem like we're seeing younger and younger people developing cardiovascular disease in the last few decades. And this is a problem, of course. I want to discuss the theory of atherosclerosis. I have touched on this in previous videos, but just for review, if you have not seen those, think of lipids as energy transport methods. The liver is your home base. It produces particles such as VLDL, very low density lipoprotein particles. These particles exit the liver. They carry cholesterol and triglycerides in them. These particles deliver cholesterol and triglycerides to tissues and are converted to other size particles such as IDL, intermediate density lipoproteins, and LDL, low density lipoproteins. This group of particles has a protein on the outside surface called an Apolipoprotein B particle. There's only one of these particles per LDL, IDL, or VLDL particle. This protein helps the liver to recognize this particle by a receptor and take this particle out of the bloodstream back into the liver for further processing. We haven't mentioned HDL particles, high density lipoprotein particles yet, but we'll just talk about those now. HDL particles have an apolipoprotein A on the outside of them. It is felt that the job of the HDL particle is to balance the job of the LDL particles. It has a process called reverse cholesterol transport that helps to get rid of excess cholesterol from peripheral tissues. It seems to have anti-inflammatory and antioxidant effects. When we look at lab work, then we are checking to see the number of particles that have the apolipoprotein B on their outside or the apolipoprotein A. In atherosclerosis, it is felt that this energy transport has gone haywire. We have LDL particles floating around. Some of these LDL particles get damaged from either inflammation or high glucose environment. This causes a damage to the apolipoprotein B particle. When this occurs, the receptor on the liver does not recognize this apolipoprotein B particle, and this particle stays in the bloodstream longer. In theory, this gives the particle more time to become damaged and also to become what is called a small dense LDL particle. Glucose causes a double whammy as it interferes with the endothelial glycocalyx. This is a layer of proteins and starches on the inside of your blood vessel that regulates multiple things such as adhesion and clotting, as well as constriction or dilation of the blood vessel. Fructose, which I've discussed in another video, if it is high, causes the generation of uric acid, which is also inflammatory and can damage the blood vessel. The thought is that damaged small dense LDL particles in greater number have a greater opportunity to invade the blood vessel wall. When this occurs, your immune system recognizes this. Macrophages, an immune cell, take up this LDL cholesterol and become what are called foam cells. And these are commonly found in plaques. Due to an inflammatory process and increased clotting propensity, you will see a rupture of this plaque and a clotting cascade that results in a clot in the interior of the blood vessel that blocks downstream blood flow. If this occurs in the heart, then you have a heart attack. If this occurs in the brain, then you have a stroke. Definitely glucose, fructose, and uric acid have a part to play in this process. Now that we have discussed atherosclerosis and some basics, our job is to decrease your cardiovascular risk if possible. There have been some confounding findings. If you talk to a cardiovascular surgeon who actually knows the lipid profile of his patient and is at surgery looking at the interior of the blood vessel, the findings don't always correlate with findings on the lab work. Many doctors will also be surprised when they find out a patient of theirs has apparently normal lipids, but yet has died of a cardiac event felt to be secondary to atherosclerosis. There are some limitations in our lab work and our risk stratification for sure. One confounder is the LDL-C, which stands for LDL cholesterol, is not directly measured. It is a calculation based on a formula. The LDL-C is a mass calculation. It does not account for the number of particles. If you have very large LDL particles or very small LDL particles, you would not know the difference based on an LDL-C lab work reported value. This is important because the size of the LDL particles seems to make a difference in outcome. There are what are called small dense LDL particles and large buoyant LDL particles. The large buoyant LDL particles do not seem to decay to small dense LDL particles. The large buoyant LDL particles seem to be less atherogenic or prone to form atherosclerosis. An apolipoprotein profile can help us to sort that out, as that is looking at the number of particles rather than the mass of particles. At times, even up to 25% of the time, according to studies, the mass of the LDL particle does not match the particle number. It can be wrong in a positive or a negative way. Many experts suggest that you risk stratify patients with apolipoprotein profiles in addition to a standard lipid profile. Some experts recommend avoiding a standard lipid profile altogether as it causes confusion. For my patients then, if you have an increased apolipoprotein B to apolipoprotein A ratio, in theory, your cardiovascular risk should be increased. In some patients, if you change your diet and exercise more, you can beneficially affect this ratio. Avoiding carbohydrates, avoiding sugar, avoiding fructose seem to be reasonable attempts at decreasing your cardiovascular risk. If you are found to have an unfavorable apolipoprotein ratio, even despite lifestyle intervention, then how would we lower this? One option is to use cholesterol-lowering medications such as statin medications. Statins were discovered in the 1970s by a Japanese researcher. Statins inhibit HMG-CoA reductase, which is an enzyme in the pathway of cholesterol generation. The liver then generates more receptors, and as a result, increased uptake of LDL from the bloodstream occurs. Statins are recommended for patients that already have known heart disease or atherosclerosis, recommended in patients that have diabetes aged between 40 and 75 and an LDL cholesterol greater than 70. Statins are recommended in patients that are otherwise healthy that have an LDL cholesterol of greater than 190. Statins are also recommended in people between age 40 and 75 that have an intermediate 10-year risk of cardiovascular disease and an LDL cholesterol between 70 and 189. Studies are definitely not black and white regarding statins, cholesterol, and cardiovascular risk. I reviewed a study from 1997 in the Journal of Circulation that looked at insulin levels and apolipoprotein B levels with relation to cardiovascular risk. If the insulin level was less than 12, patients had very low cardiovascular risk, irregardless of what their apolipoprotein B particle number was. However, if the insulin level was greater than 12, those with higher apolipoprotein B particle numbers had a greater cardiovascular risk. This implies that diabetics or people with high insulin level need to have diabetes well controlled. This creates a little bit of a problem as statins can worsen blood sugar control and increased risk of diabetes. Statins do increase risk of liver injury or elevated liver enzymes. This is a complicated area, as many patients that have metabolic health disorders have non-alcoholic fatty liver disease and elevated liver enzymes at baseline. It is likely that treatment of many of these patients does not worsen this condition. And if patients have lifestyle intervention that improves their fatty liver condition, as well as statin therapy, their liver enzyme readings may actually improve. I read a journal article from 2020 that looked at a cohort study of populations of patients, and either very high or very low LDL cholesterol seemed to increase all-cause mortality, cancer risk, and risk of cardiovascular death. Unfortunately, statins don't do the job for everyone, and as many as 80% of those treated with statins still have residual cardiovascular risk. We have other medications to add on, such as ezetimibe and monoclonal antibodies. I've read articles that show that statins increase calcification. This is confusing because we look at what are called coronary artery CT scans or coronary calcium scores to help risk stratify patients. If statins increase calcification and increase coronary score, then how do we interpret this? There are many articles for and against statins, some of which state the benefit is overstated. Oftentimes these articles cite relative risk reduction instead of absolute risk reduction as statistical trickery, and I get it. I also understand that the benefit of statins may be understated, and the studies don't go out long enough or as many years as needed to see what would happen in someone that uses a statin medication for 50 plus years. Some of these studies I'm referring to, when looking at statistics, will show that you may have only a month of increased lifespan with statin use. The take-home point for my patients is when I get a lab test and I'm looking at apolipoprotein numbers, I'm looking at the number of particles in your body, and if there's a way I can change this to be more favorable for your cardiovascular risk, I will do so. If you're my patient, I hope this information can help you to gain more understanding about apolipoprotein particle numbers. If you're not my patient, please see your own doctor for diagnosis and treatment. This is Jason Williams, DO. This is the Williams Family Medicine Channel, helping you to live your best life.